Donc, il est midi 2, on va commencer. Bienvenue, Dr Fontaine. Je vais faire votre introduction et après, vous pouvez commencer votre présentation. Merci. Donc, merci d'être avec nous aujourd'hui. Dr Guillaume Fontaine is an assistant professor of implementation science at the Ingram School of Nursing at McGill University and a principal investigator at the Center for Clinical Epidemiology at the Lady Davis Institute for Medical Research. He also serves as nurse scientist for implementation science at the Sir Mortimer Davis Jewish General Hospital. Dr. Fontaine holds an FRQS Junior 1 Research Scholar Award supported by its Learning Health System Support Unit. He is the national co-lead of implementation science in the CIHR-PHAC Canadian Network on Hepatitis C and the national co-lead of methods in the CIHR Canadian HIV and STDIS Clinical Trials Research Network. Additionally, he holds visiting appointments at the Kirby Institute, UNSW Sydney, and the Center for Implementation Research at Ottawa Hospital Research Institute. Dr. Fontaine is an academic editor for PLOS Global Public Health and a guest editor for the International Journal of Drug Policy. Welcome. Thank you very much.
Thank you so much for the warm introduction. So can you hear me properly? I just want to make sure that you can also see my slides. All good? Great.
Yeah.
Excellent. So I am excited to be talking about implementation science today, which is one of my passions. And this is really my role at McGill. So I was hired specifically to advance the field of implementation science conceptually, in terms of methods and also how it's applied within different clinical areas. So I'm going to be talking about specifically today about the intersection between health equity and implementation science and what types of methods can be leveraged to achieve the goal of improving health equity. Here are some of my disclosures. So what I do at McGill, so like Christina mentioned, I hold 2 leadership positions in national networks. So the first one is around the Canadian Network on Hepatitis C. So hepatitis C is one of the key infections globally that we can eliminate over the next several years because we have new treatments that are highly effective. But the challenge is bringing those treatments to the populations who need them most. And those populations are highly marginalized. So people who use drugs, who inject drugs, people who are incarcerated, immigrants and newcomers to Canada, Indigenous peoples. So 85% of new HCV infections occur in people who inject drugs, just to give you an idea of the epidemiology. So we are using implementation science within that network to bring treatments and tests to those key populations. And then I also hold a leadership position for methods, including implementation science within a new network that's been refunded. That is now has a different shape. So the Canadian HIV Trials Network, which I think it exists since maybe the 90s, so 35 years approximately, has been refunded, but its scope has been broadened to include all sexually transmitted and bloodborne infections. So including viral hepatitis B and C, sexually transmitted infections like chlamydia, gonorrhea, trichomoniasis, syphilis, and other emerging infections as well, like Mpox. So what I do essentially is a lot of my research is focused on implementation research to promote high quality infectious disease care. So improving testing, linkage to care and treatment for viral hepatitis B and C, HIV, COVID, some other infections as well. I also conceptually am really interested in health equity and related constructs like stigma, intersectionality. I'm going to talk about those a bit more today. And also I'm doing a lot of research around the methods that we use in implementation science. So how can we more effectively assess the barriers and enablers to implementation? How do we design strategies to improve care and so on? And across all of those different areas, I use a range of methods: quantitative methods, qualitative methods, and mixed methods. So I'm going to jump straight into equity and its importance in healthcare improvement. And to me, the importance really of equity is reinforced by the political context that we see in the US right now, and equity is really under attack. So we have to keep doing this work and really move things forward in Canada with leadership. So the global imperative for health equity is, I would say, it's something that started more than 20 years ago. But there were a number of position statements from the Pan American Health Organization, the WHO, Commission on Social Determinants of Health, and a range of other position statements that recognize improving health equity as a critical and increasingly urgent goal across different health sectors. And really, we have over a century of evidence that links poor health outcomes to the inequitable distribution of resources, power, and wealth in society. And there's a lot of scholarship that's focused on critical theory, for example, to explore the links between power and health. And that has led to some of those global statements as well, and all of that data, of course, across those social determinants of health. What I like to talk about as well in the context of achieving health equity is to talk about the risks in society, and that is a graph that was developed by the World Economic Forum in 2023 on the different groups of risks to society. And essentially, the risks in red are led to society broadly, but a bit more closely related to health. And then you have other risks as well: environmental risks, geopolitical risks, and so on. And I really think that as we contend with all of those interrelated challenges and crises, prioritizing equity can be a guiding light and something to guide the work that we do across sectors. So equity, what is equity? So equity can be defined in different ways. If you look at the literature, the recent literature, and I really like this paper by Plamondon, who's a professor at the University of British Columbia, and she outlines equity in 3 different ways. The first one is equity as more of a concept or a construct. So as a worldview, thinking about justice and fairness in society and how our society is set up to function and work. The second way to think about equity is as a benchmark. So as something that we aim to achieve, right, as a goal. So as a standard for guiding our efforts to improve healthcare. And really this way of thinking around equity emphasizes fairness and outcomes of what we do. So it's really not just an aspirational goal, but is really meant to be an achievable goal for the research and the work that we do. And the last way to think about equity is equity as something that's experienced. So the experience of how individuals feel and navigate equity or its absence in their interactions with the healthcare system. And really it manifests itself at an individual level, but also at collective levels among different groups that are marginalized and that face inequities. So I think it's a great way to think about equity. I mean, in terms of research, what I do touches on those 3 conceptualizations of equity, I would say, but often a bit more in the experience and also in the blue section in terms of benchmarks and the inequities that we observe. In terms of the concept of health equity in healthcare improvement, so most of you have probably seen this paper published in JAMA a few years ago on the quintuple aim for healthcare improvement. So now saying that, yes, the triple aim, we should focus on improving patient experience, improving outcomes, lowering costs for the healthcare system. The quadruple aim, including clinician well-being, is also added in 2014. And in 2021, the health equity aim has also been added, and essentially saying that we should focus on all of these aims across projects that we're developing. And this has been reflected in multiple documents, for instance, from the Canadian Institutes of Health Research, that mention that, Equity is the single most powerful concept for accelerating health improvement around the world, and it is an opportunity to lead for us. So what types of outcomes are related to the quintuple aim? So we're quite familiar, of course, with, health outcomes, experience outcomes, cost outcomes, and the work life for staff. But when we talk specifically about equity, we're going to be looking at health disparities and social determinants of health. And then you have different surveys and metrics that are linked to those outcomes, different outcome measures. So when we're talking about social determinants of health, I like to refer to this WHO framework it's really an operational framework for monitoring social determinants of health equity. And they delineate two groups of determinants. So structural determinants that are really related to policies, governance, social policies, public policies, culture and societal values, and those intersections with, for instance, socioeconomic position, social class. And they also specify, like I said, intermediary determinants, social determinants of health. And those are closely related to the behaviors of individuals, biological factors, psychosocial factors, and all of these interact and intersect to have an impact on equity in health and well-being. So I think it's important to have those determinants in mind as we move forward. So what's the link between equity and implementation science? So implementation science, as you might know, is really the scientific study of the methods that we use to support the integration of evidence-based practices and programs in healthcare. So we're really having a methodological focus to generate a body of evidence about what works for whom, why, and under what conditions to improve the uptake of an intervention. So really the different reasons for why implementation science is needed is there. First, the most common reason is that we have slow uptake of new interventions that are clinically effective. We have a new vaccine, a new treatment, a new medication, any type of intervention that's demonstrated efficacy or effectiveness, and we want to put into practice, but really it's proving difficult for a range of reasons. So the slow uptake of those interventions is a first reason to leverage the field of implementation science. And we often call this the failure to deliver high-value care. The second reason is the premature or continued uptake of interventions that are shown to be ineffective, wasteful, or harmful. So for instance, for clients who have low back pain, we know there's been a lot of evidence shown that we do too much imaging for low back pain. So there is more risks than benefits associated with that. So there's a specific field within implementation science that's called de-implementation that looks at reducing low-value interventions. The third reason why we need implementation science is that, generally speaking, we have a range of interventions that are currently embedded into clinical practice one way or another, but we have emerging evidence around those interventions, and often we're not keeping pace. We're not keeping up with the pace of evidence around existing interventions. So implementation science can help us in those methods to update what we do on a regular basis. The fourth reason is around clinical ethics. So sometimes, we really have trouble keeping up with changes in the ethos of care, and we might not have 50 randomized controlled trials showing that we need advanced care planning, for example, but we know that for ethical reasons, we should scale up this intervention. So that's the fourth reason. And the fifth reason that's really related to my talk today is that we observe, of course, a lot of unwarranted variations in the level of care in the healthcare system, and those are associated with health inequities. So often when we implement a new program, intervention, treatment, technology, or so on, the populations that will benefit first are those that are most connected to the healthcare system, and the populations that are less linked to the healthcare system will not benefit as well from those innovations. So taking that in mind, that's a reason to leverage implementation science to engage those populations, look at personalized strategies to engage them in care, and also make sure that they have access. When we talk about implementation science, I also like to refer to the thing, right? With like the movie. And this is a Jeffrey Curran, so he's an implementation scientist in the US, and he has this analogy where he says that the intervention, the practice, the innovation that we're putting into practice is the thing, right? So a treatment, a test, any type of clinical practice that we want to improve. And then effectiveness research looks at whether the thing works, right, on client outcomes, so improving different client outcomes. Implementation research looks at how best to help people in places do the thing. So how do we help providers and services to improve the uptake of this intervention? And those are implementation strategies. And then the main implementation outcomes are how much, how well the providers and services will perform a given intervention. So this is just a bit of language to frame the field of implementation science. And some of the core components of implementation science are really looking at, is there a quality or care gap first? And then, is there an evidence-based practice that we want to put into practice? Is there robust evidence base around this practice? Do we have the expertise as well to go about changing practice? Assessing readiness for change. And really the central piece of implementation science is using conceptual models, frameworks, and theories. So those frameworks, models, and theories have been developed within the field, building on decades of research in psychology, organizational theory, sociology, behavioral economics about what works in terms of scaling up an innovation or changing clinical practice. So if we're not drawing on this body of evidence within the field, we're really not doing implementation science. So we have to use those tools. And then other key concepts within the field and components are the implementation strategies that I just talked about. So the how we go about implementing something like training, education, quality assurance, choosing champions, providing reminders at the point of care, changing incentives and financial structures. So all of those are implementation strategies. And then engaging stakeholders, the different study designs, and the implementation outcomes are also some of the other core components. When we think about implementation science, like I said, we have to use some tools. So some of these tools, broadly speaking, the red component of the tools that you're seeing on the screen, those process models are meant to guide the process of putting an intervention into routine use. So if you want to scale up an intervention, those process models will specify essentially a series of steps to do so, making sure that you use a structured approach. The gray section of those models and theories is looking at understanding the barriers and facilitators to implementing a new intervention. And the black, the evaluation frameworks, are meant to help evaluate the impact of an intervention on implementation outcomes, service outcomes, and client outcomes. So really, when I'm going to be talking about some of those tools, I'm going to be looking at those three broad categories. And then what is implementation research? So what I like to draw as a parallel is that often, in typical, I guess, clinical research and some of those clinical trials, you would be looking at what is the effect of an intervention, a practice on client outcomes in terms of health, in terms of other outcomes like function and symptoms and so on. But when you're looking at doing implementation research, you look at how you're going to put into practice this intervention, what are the barriers and facilitators that you're going to address, what are going to be the implementation outcomes in terms of acceptability, feasibility of delivery, costs, appropriateness, what is going to be the impact on service outcomes in terms of patient-centeredness, equity of care, like I just talked about earlier, and timeliness of care. And if we do a great job at improving implementation outcomes and service outcomes, then we're going to have great results on client outcomes. So the core of implementation research is really focused on this middle portion. So the how, which factors we're addressing, how are we improving implementation and service outcomes. So the client outcomes part we're still considering, but it's not the primary focus of what we do. And then, it all starts really with what is your implementation question? What is the evidence-based intervention, practice, or policy that your project is focused on implementing? And I like this figure as well, showing the continuum, essentially including implementation research, where you go from pre-intervention in terms of thinking, could a program work, to efficacy studies and effectiveness studies with the question that, does the program work? And then the implementation part in orange and yellow is around making a program work and looking at implementation and sustainability. So now pivoting again a bit more to equity and implementation science and how those things intersect. So I attended last year a great meeting. It's a working meeting, so it's not a conference, but it's a working meeting with different implementation scientists in Europe and Canada. And this one was held in Sweden. And I did a workshop with some colleagues that I'm highlighting on this slide from Australia, Canada, and Europe. And we essentially had a great discussion on the intersection between implementation science and equity, and focusing on what doing equity-oriented work means, really. So I like to show the notes, some of the notes that we took during this meeting. It was quite interesting, so I'm going to highlight a few things on those notes. So first, some of the things that came up is that equity implications are always present in the work that we do in one way or another. And that every study is an equity study when we're talking about, applied health research, because the equity considerations are woven into the fabric of, really all research, because we work with diverse populations with different socioeconomic statuses and levels of access to resources. We know that there are some disparities in how interventions are accessed and their outcomes. And of course, we're working within a economic and political context, which influences how we do the work. So those are the first few things that came up at first. Then, there's also what came up is that, doing equity-oriented work is complex, hard, disrupting, and we need to position ourselves. Complex because, of course, we're looking at many different factors, including ethnicity, gender, socioeconomic status, and so on. Hard because we're going to need to change some entrenched systems and practices often. It's also disrupting because we're looking at changing power structures and norms, and that can be, of course, uncomfortable, controversial as well. And also positioning ourselves because we always should be learners around equity and having self-awareness and reflexivity. And the last few things I want to highlight here are some foundational principles around, having authentic connections, authentic and meaningful relationships, solidarity, reciprocity, and research co-production. With the groups that we're working with when we're seeking to embark on a journey of equity-oriented research. So some guiding principles for embedding equity in implementation science. I would say that the first one is, thinking about those tools that we use. So making sure that I'm going to present a few examples. With the frameworks that we use, the methods that we use, that there's an explicit attention to the culture, the history, the values, the strengths, and the needs of the communities that we're working with. So this is potentially the first guiding principle. The second one would be to make sure that, we're clear about which communities we're working with and specifying that from the onset of the project and working with communities that don't have the same level of access to services as other communities. The third guiding principle would be to really have a critical perspective and a deeper understanding of the systems and policies and what are the key barriers at different levels to improving care. And the last guiding principle is, of course, around engagement and partnerships with different communities, making sure that we're working towards shared goals, and we have an equitable distribution of power in the research project. So quite a few papers actually over the last few years have looked at the intersection of implementation science and equity. And those papers have, they've been published in the journal Implementation Science. Quite a few as well have been published in the Annual Review of Public Health. And those papers really highlight essentially, why we should give higher priority to health equity in the context of healthcare improvement, but also discuss, some challenges and opportunities. They discuss as well some methods that we can use to advance the field. So I'm going to summarize a few of those. So how can health equity more specifically guide the research approach? So beyond, key principles, what we actually need to do is engaging and partnering throughout the implementation process with the key communities. So, looking at establishing collaborative relationships with the groups that we're working with, making sure that we have proper systems for communication and reciprocity. We also need to define the problem with an equity lens. I'm going to talk a bit more about that. We can also reevaluate existing evidence or existing interventions to see if those were designed with an equity lens. That's something that we can do through evidence synthesis and systematic reviews. We can also integrate equity into research design. We can select and adapt strategies and interventions that specifically promote health equity or address social and structural determinants of health. And the same for implementation strategies. And we can also integrate equity into the measures and evaluations that we use. So I like this decision tree, and this was Matthew Chinman and colleagues who developed this decision tree around, is there first, essentially how to incorporate implementation science research designs into health disparities research. And they talk about different steps and phases, the first one being around, detecting health inequities and disparities, looking at the data and looking at, what needs to change. The second phase being exploring the underlying mechanisms that lead to those outcomes. And then, the phase 3 is really about looking at interventions and implementation strategies to reduce those disparities. So that's an interesting paper to read in terms of process, really. But if we're looking at, defining the problem with an equity lens, what does that mean? So first, it's really about clearly defining the disparities, the affected populations, and the social determinants contributing to the health inequity. So often you look at some guidelines and papers that touch upon this, it's about clarifying the performance gap for an intervention in vulnerable populations. What is the level of access to point of care testing or testing for hepatitis C in this population versus this population, and looking at different settings as well. How do these compare? And also looking at the outcome gap. So performance gap for those interventions, the outcome gap as well in terms of health outcomes and client outcomes, and looking at how those gaps differ across populations and settings. And also looking at the barriers that are faced by populations in relation to those performance gaps and those interventions. In terms of reviewing and selecting interventions with equity in mind, if we have a good understanding of the problem, of the evidence, of the performance and outcome gaps, then we can look at the evidence that's out there regarding equity promoting interventions. So I like to give this example. Colleagues of mine published a review quite recently in the Lancet Infectious Diseases on the effectiveness of interventions that are focused on social determinants of health for improving hepatitis B care. So that's a really good example of the type of evidence synthesis that we need more of. So going beyond interventions that address individual determinants like knowledge and skills and some of those other determinants, to focus on the broader range of social determinants of health that I presented earlier. So we can do, we can look at existing evidence synthesis that have been done in this context for different clinical areas, or we can also reinterpret the evidence base ourselves by doing systematic reviews that are equity focused like those. And we also have to think about adaptation of those interventions. So that's something that the field of implementation science can help with. For example, the adapted model has been developed in the field of HIV to look at, you have a given intervention that's demonstrated some effectiveness for a given population. How are you going to adapt this intervention to make sure that it's culturally safe and also adapted to the needs of the community? So the adaptation piece is also a big component after you've identified those interventions in the previous step. Some other tools that can be leveraged. So I like, there's a scoping review that was published in Implementation Science 2 years ago on equity-oriented or focused theories, models, and frameworks. So either frameworks that can be used to assess barriers, facilitators to care and to implementation, or frameworks for evaluation as well, different types of frameworks. And essentially they looked at the different attributes of those frameworks to assess which ones were more closely aligned with equity. So what they did essentially, so they, that's the first output. So they did scoping review, but another team of authors also examined another set of theories, models, and frameworks with different criteria to look at whether or not they were equity focused. And I like the way that they've, the type of criteria that they've used. So, making sure that there's an explicit focus on equity, health disparities in the framework, making sure that there's an inclusive conceptualization of knowledge in the context of the framework. It outlines methods for stakeholder engagement. There's an explicit focus on interactions across jurisdictions or sectors. There's an influence on context and the barriers to care at different levels. And there's also a proactive problem-solving approach that's promoted. So that's also an interesting resource that assessed 48 theories, models, and frameworks. Some other examples, so if you look at the field of the determinant frameworks, so those frameworks that are meant to assess barriers to care and to implementation of a new intervention, the most widely used framework in implementation science today is the Consolidated Framework for Implementation Research. So it includes many, many different constructs and levels. But basically, it says that if you want to put into practice a new intervention or new practice, you have to look at barriers at 5 different levels. Levels of the innovation in itself, the practice, the outer setting, so the broader healthcare system and policy context, the inner setting, so the clinical context, individuals, so providers and patients, and you have to look at the implementation process. So this framework is widely used today. But if you look at, the author, the original author of this framework, she clearly says in her paper that it's really an imperative to combine an equity-focused lens with this framework to make sure that you, include some of those marginalized populations in the implementation process, and you're not missing out on some critical health equity considerations. So a number of people have done work to adapt some of the implementation science frameworks to include a more health equity oriented approach. So this is a really good paper published in the the journal Translational Behavioral Medicine, looking at, making some adaptations to existing frameworks to account for health equity considerations. And that's a very interesting read. And they talk about a wide range of theoretical approaches. Some of the examples that they outline, for example, is the CFR, so the framework that I just mentioned to look at the barriers at different levels. but this group of investigators and authors adapted the CIFER by adding a public health critical race praxis in the framework. And really, their research revealed a significant influence of racialized factors, such as the perception of discrimination on the adoption of interventions. So by adapting this new lens, they were able to uncover additional factors that influence whether or not people will engage with care. For example, they showed that the ethnicity of people in authority and the extent of the network of key implementation actors within their community really determine the engagement with these programs. So essentially, if people in power looked like the people who were in the community, the people in the community were more likely to engage with the program because they identified with the leaders and the community leaders and so on. There's also another framework that was adapted, another determinant frameworks to look at the barriers and facilitators that was adapted to include healthcare disparities framework as well. So this one was applied in the context of hepatitis C virus treatment to make sure that in addition to looking at barriers and facilitators, we also identify at the same time, gather additional information on those health disparities. Some of the work that I conducted over the last few years is exploring the impact of stigma. So I conducted, some work with people who inject drugs within needle and syringe programs and harm reduction programs, and really showing the impact of stigmatization on the willingness of people to engage in hepatitis C care. The fear of stigma really acted as a key barrier. And for example, there was a lot of stigma around the fact that people in reality can be treated multiple times for hepatitis C. So, they can be treated once, they could be treated twice if there's a reinfection. And really the best practices and the public health evidence shows that there's more benefits to retreat an infection than just, treat it once, of course, because, but there's a lot of stigma in providers around, be careful because we're only going to be paying your treatment once. And if you get reinfected, you're going to be stuck with it and stuff like that. That's, that was said by providers. So that, has a lot of stigmatization that's internalized and that, precludes people from seeking additional care when they should really do it. Another study that we conducted, so we conducted a study looking at barriers and facilitators to hepatitis C testing among people who inject drugs and service providers. And we use an intersectionality lens. So we looked at, and what I mean by intersectionality really is looking at how the different facets of someone's identity influence whether or not they're going to be engaging in care. And it's looking at, because a lot of those people have stigma based on the infection, right? The hepatitis C infection, but they might face also stigma because they are homeless and, they're also transgender or, they're homosexual or, they're racialized. There's, a lot of indigeneity as well in the people who are living with hepatitis C in Montreal. So all of those things interact and intersect to create more barriers and than if it were for a single of those factors or characteristics. So intersectionality really looks at, uncovering the life story essentially of those people and looking at, how this life story and those characteristics influence whether or not they're going to be seeking care. So we developed a new approach for, essentially embedding an intersectionality lens in implementation research. So starting with, which questions are you asking? Which research questions are you asking? And then making sure that you select an appropriate framework to guide your research. How are you going to collect data in a way that's aligned with intersectionality as well? how are you going to analyze data, interpret, and disseminate knowledge as well. And one of the key things that we really uncovered is that for this specific study is that we had the first question in the interviews that we conducted around, what are the barriers for you to engage with hepatitis C care and testing and treatment and so on. But the other question was around, how does social identity and racism and some of those other barriers intersect with those other barriers that the person was mentioning. And we first had very directed questions around those things. And people, especially with lower health literacy, have a lot of difficulty expressing the barriers that they face. That's something. So when you have those interviews with people, sometimes, someone is going to be homeless, someone is going to be injecting drugs, they have hepatitis C, HIV, a bunch of sexually transmitted infections, and they might, of course, not see the full extent of the barriers that they face and how their own life stories influence those barriers and everything. So we kind of shifted the approach to having them from a more structured way of exploring a social identity and those barriers to a more life story approach, where we had some conversations with people to look at, tell me how you grew up and kind of your background, your education, your family. Tell me about your social circles and the people in your life. And having that more unstructured approach to exploring social identity and those barriers was really effective in bringing up things that for them constituted important barriers to accessing care. So that was quite an interesting finding. And you can look at the paper and the findings. And in the paper, we present how are the key barriers structured for clients, people who inject drugs, and also what are the barriers for providers to offering testing and offering hepatitis C care. So we looked at the problem from two different dimensions. So a few last words. So once you've identified the problem from, an equity perspective, and this can be done in multiple ways, right? So it could be done with quantitative data, can be done with qualitative data, and optimally you would combine both. So looking at, what the quantitative data says and looking at the life experiences of people as well. And then you need to think about how you're going to improve access to care and looking at the implementation strategies that you're gonna use. So one example of co-designing strategies to improve access to care that we conducted over the last few years was in Ontario. So we conducted a study with 3 different communities. So people in Toronto, people in Peel, and people in Ottawa. And we work with different cultural communities to co-design strategies to improve access to COVID-19 vaccination. So what we did is this is the process that we took. So we first, aligned. The first step that we took really was working with the Ministry of Health of Ontario and the leads of the public health units of Ottawa, Peel, and Toronto to look at, what is the data regarding the disparities regarding COVID-19 vaccine access. So we look at epidemiological data on different, regions really within Ottawa, within Peel, within Toronto, and those regions that would benefit the most from having additional support. So that was the first step, kind of understanding the disparities, understanding the priorities and the needs. And then we really, from that point, work with community leaders. So we work with representatives in different community organizations, cultural associations, religious associations to identify community leaders within each really neighborhood that we were working with. And we built community advisory groups for each region. And we engaged with those community advisory groups over the course of a year and a half to build relationships, establish an engagement framework. And then we ended up doing interviews using similar approaches that I've outlined before to understand the barriers and enablers to accessing COVID-19 vaccination for them. And then we co-designed some strategies with them as well. And then those strategies were essentially, fed back to the public health units, who adapted the strategies that they used for providing access to vaccination for those populations. So this is a way to essentially do community engaged work that's implementation science informed in the context of public health. And finally, just I have two slides left in my talk. So the first one is that we have a lot of challenges to do this work. First is that there are very few interventions that include a systemic approach and that address upstream social determinants. And really the current evidence-based, if you look at Cochrane, if you look at all of those different systematic reviews, very little reviews have been done looking at specifically equity promoting interventions or interventions that address social determinants of health. So the evidence base is growing, but we do need to do a lot of work. And across different studies, of course, we have huge lack of diversity in study samples and contexts, and that's really limiting the applicability of the results. The second challenge is that we have, broadly speaking, underdeveloped methods and measures. So we need to do a lot of work in that area as well. And also, generally speaking, there's an inadequate attention to context in the work that we do and the barriers that are in the context. And that's often attributable to lack of resources, lack of time, lack of many different things, but it's something that's posing a big challenge for sure. And finally, we're making progress. Like, for example, this WHO new resource that's on health inequality is really quite interesting. So it's a data repository outlining different health inequality measures across different areas, different clinical areas and populations. So having access to that data is really quite important, but we have a lot of work to do on disaggregation of data to highlight some of those disparities at the level of population groups. But I'm quite optimistic that we're going to be able to continue working on that, even if the context is difficult. So thank you for listening to me. I've been speaking for quite some time. I hope this wasn't too boring, but if you have any questions, I would be happy to answer and to discuss.